Well, we appreciate the work of DOH and all the agencies in New York State. I know Staten Island has been hit very hard by the epidemic, but I know with my colleagues, it's not just my district, but it's all over New York State. So I know it's something that we all have to work together on. Could you just, I see I have a couple more minutes left. Could you just give me on ISTOP? Is there any updates on the results of ISTOP to this date and where we're moving forward on implementing certain changes in ISTOP or certain areas that we needed to just tweak a little bit?
Well, we've had much success with this, and this is part of the way to tackle the issue that we're dealing with. I can get back to you on the exact numbers of where we are on that, but I am optimistic that this will help tackle the opioid problem as well.
Okay, great. Thank you, Mr. Chairman.
Thank you very much. We've been joined by Assemblyman Felix Ortiz and Assemblyman Jeff Aubrey. Senator.
Thank you, Assemblyman. We've been joined by Senator Phil Boyle, and so I'd like to take my turn right now to begin. First of all, I totally agree with Senator Hannan that you and the department have had many significant accomplishments this year, and I really compliment you on that. I also want to personally thank you because, as you know, we've had very serious issues, especially related to hospitals in my Senate district, and you and the department have been phenomenal as far as being responsive and very effective. So kudos to you and sincere thanks. I did have some questions, and the first one was regarding the global cap, and the state is estimated to spend about $17.95 billion on Medicaid in this fiscal year. And during the budget briefings, we were provided with a Medicaid redesign team, MRT, budget proposals chart that detailed $270 million in new Medicaid investments that are offset by $270 million in new Medicaid savings initiatives. So aside from the chart, however, is there any other accessible public document that provides a detailed accounting of the projected $17.95 billion in Medicaid expenditures, including what is assumed to be in the base year from prior year MRT initiatives?
Certainly, there's quite a bit of additional documentation. Happy to work with your office to get you all the information that you need. We try to manage the global cap in a transparent fashion. There's a lot of moving parts, a very large and complex program, but happy to get you additional information as desired.
Look forward to getting that. Thank you, Mr. Halverson. During this fiscal year, the estimates show that there are emerging pressures on the global cap due to higher than expected enrollment. Is the global cap on track to remain balanced through the conclusion of this fiscal year after accounting for higher estimated deficits? And if not, is the department prepared to develop a Medicaid savings allocation plan as outlined in the statutes?
We believe we will finish the year within the confines of the global cap, and we are not in the process of developing a Medicaid savings allocation plan.
So even though there's increased enrollment, you believe that you'll be able to stay within the boundaries?
Correct. Yes, we have been successful over the last 4+ years of managing within the confines of the global cap, and so while this year is certainly challenging, we believe that as we proceed towards closeout for the fiscal year, that we have a path to close the year in balance.
Okay, thank you for that. The fiscal year 2016 global cap mid-year update estimates a deficit of $377 million, and this deficit is closed by decreasing funding for numerous programs, including the Vital Access Provider, the VAP funding for financially distressed hospitals, and as you know, that's a particular interest to me. What is the rationale and process that goes into the decision to reduce Medicaid funding for these specific programs, and what factors are considered?
Sure. So in terms of the VAP adjustment for closing this fiscal year, I think the idea was that, as Commissioner Zucker mentioned, the state is investing significantly into facilities of varying types. And so as an effort to basically close or help to ensure that we could close, we have made a slight reduction in the available funds for the VAP program. That said, if it turns out that we don't need to make that reduction, we have the ability to then, in essence, restore those funds and maintain the program at that current appropriation. We've had a very successful year in terms of matching some of our state investments with federal funds. And you see that the governor's proposed budget for next year, in essence, ensures that not only do we maintain, but we significantly expand upon resources available for financially challenged providers, with the funds growing to $450 million just for hospitals for next year. So while it certainly is a challenge, and we look at every dollar within the cap to see if there are ways that we can economize, even if on a temporary basis, we feel at the end of the day we have sufficient resources to meet the needs of providers, while at the same time allowing us to close the year with a balanced global cap.
And some of those, and there are 28 hospitals that were in the VAP app, which 11 of those will transition into the value-based payment quality improvement program. So we are moving forward with that. As you're aware, the VAP app was the state funds, and the value-based payment QIP is including federal funds.
Okay, thank you for that. I wanted to switch gears to the minimum wage, and as we know, in the executive budget, there's a proposal to increase the statewide minimum wage to $15 per hour, although no funding is identified within the health Medicaid budget to help entities such as nursing homes, hospitals, home care agencies, and other providers that have a finite amount of existing resources to cover increased labor costs. I've had providers come to me, nursing homes, for example, who have said that if this $15 an hour goes forward, there is no question that we will have to shut our nursing home. So the question is, how will this be addressed in the context of the budget? And also, how many nursing homes and hospitals are currently designated as financially distressed? Because we do know that there are a significant number of hospitals and nursing homes right now in New York State that already are under dire financial pressures. And so how are we going to deal with this issue?
Okay. So there's two parts to that. The issue of minimum wage, the governor has proposed a multi-year phase-in for the increase in minimum wage, and we will work with, as we negotiate the budget, to discuss how we move forward with that. And we recognize that the impact on the workforce in general. But I will say that we've had a track record of working on phase-in projects in the past, and including a wage parity, which Jason could speak to on that as well. Regarding the nursing homes, we are looking at all the nursing homes, and we recognize there have been challenges there. I think the issue of nursing homes in general is the bigger issue of how do we move forward on long-term care, aging, home care, and so it's a more complex question, not just survival of individual nursing homes, but the bigger picture of where we're going to move forward on that. Jason, do you want to talk about the work parity?
Sure. So back in phase one of MRT, back in 11-12 budget, an item that was included in that was basically to extend wage parity laws in the New York City, Long Island, and Westchester counties where those laws existed to a subset of home care workers that had been basically exempt from those laws. And so it was a phase-in, much like the $15 wage, in that case, over a 3-year period. And we basically had to manage that implementation. And so what we were able to do within the confines of the global cap was to, in essence, raise their wages and benefits, which meant we had to pay the providers more to cover those costs. But we were able to manage it over that multi-year period. And so our hope would be to adopt a similar approach here in terms of trying to manage that. I would say also in terms of the $15 wage, I mean, I think that in the areas that you mentioned, I think we collectively believe that at the end of the day, we want a healthcare workforce, a healthcare system that is built on a workforce that is adequately reimbursed, that has wages that not only help them cover the cost of their own living, but also help to ensure that we have a stable workforce. And I know we've got plenty of experience with regards to the fact that higher wages and benefits can actually translate into a workforce that will stay with you for the long run, that will lead to better patient outcomes. And I think those are the kind of benefits that we would hope to see from the wage as a result of its implementation within the healthcare system.
So because there aren't any funds, I believe, currently identified in this budget proposal that do what you say needs to be done, is there a way that we could get some kind of plan from the department as to how you would address the $15 minimum wage? I think that would be helpful. And also, does the department keep a list of distressed hospitals and nursing homes? And could we have that?
We can get you that information.
That would be great. Thank you. I did want to ask about the Medicaid waiver. So the State and Centers for Medicare and Medicaid, the CMS, reached an agreement on the federal waiver that authorizes the state to reinvest $8 billion in federal Medicaid savings into the state's health care delivery system over 5 years, and year 2 begins on April 1st, as you know so well. The $8 billion is broken out as follows, with $6.42 billion for DSRIP, $1.08 billion for other Medicaid redesign purposes, and $500 million in IAAF funds, which is the Interim Access Assurance Funds. Are we on target for April 1st for the year 2 start?
Yes, we are on target for this. Do you want to go through the details?
Sure. Just that so far we feel like this has been exceptionally successful. It's still early days. Just last week we had the Oversight Review Panel, which is requirement and was established under the terms and conditions of the waiver, met for 2 days, and we've broken the performing provider systems within DSRIP into 2 cohorts. This was the second cohort. The New York City, Long Island PPSs all were in attendance. It was they each had an opportunity to present, so it was a good opportunity to sort of check in on where the initiative is, and there's some amazing things that are going on. We had heard earlier, sort of in the fall, we had heard from the upstate PPSs, so a tremendous amount of great work going on there. Really significant changes in the delivery system, better care for patients going on, and we are absolutely on path to continue implementing this initiative within the confines of the terms and conditions.
How will the second year of DSRIP be different than the first year?
So what I think the way I think about this is over the 5 years of the initiative, the first 1, 2, and then into also the beginning of year 3 are really what we call the infrastructure building phase. This is where the performing provider systems, and what a performing provider system is it's basically a network of providers that come together in a community, and they collectively agree to basically work together to improve the quality of care for the population of Medicaid and uninsured that they serve. And so what the first couple of years are about is launching anywhere from 8 to 11 projects that they committed to in their application. It's, as I say, investing in the infrastructure, doing things such as I mentioned earlier, the idea that every primary care provider would be a level 3 patient-centered medical home. It takes investments and effort to reach that high national standard. And so those are the kinds of things that are happening. They're also investing in things like HIT and advanced analytics so that they can actually mine their own data in more effective ways, get information into the hands of clinicians to allow them to better serve the population. And so there's a lot of work going on. This is no small task. These were organizations that never existed before. These are coalitions, in some cases, of competitors who have had to sort of set aside their somewhat natural competitive instincts to really work together for the vulnerable in their communities. And so that's really what years 1, 2, and 3 are. But as we get closer to that third year, it's going to be less about investing in the infrastructure and more about the outcomes. Because the way that the waiver works is that the out years, years 3, 4, and 5, more and more of the money is tied directly to improved outcomes. Did Medicaid patients actually see improvements in their health and well-being? Did we prevent individuals from going into the hospital when they didn't need to be there? That's really what happens in those out years. And so there's a lot of time pressure on the PPSs to get that infrastructure up and running as quickly as possible so that they are fully prepared for when that money, which is all linked to performance, is really riding on their success of actually improving the health of their communities.
So you believe that we're on target to reduce readmissions by 25% by the end of year 5? You think
Absolutely.
That's on track? And also, thank you. And also, have there been improvements because, again, financially distressed hospitals? Have you seen improvements in year 0 and 1 as a result of the DSRIP actions?
Absolutely. In fact, those IAF funds that you mentioned as an initial source were essential to helping some of these providers get to the point where we are. Obviously, in addition to DSRIP, there are some facilities that need additional assistance. That's where that $450 million comes in. That needs to be very targeted. But overall, we think we've made some strides. Still a lot of work to be done. There's no question that some of these institutions are going to take several years to transform. But we're very excited. There's some really exciting initiatives designed to help these institutions basically transform into things that are going to be much more sustainable. And we're very excited to get ongoing here into the second year to really start seeing some of those investments starting to be made.
Thank you. And one final question. What percentage and amount of DSRIP funds are expected to flow beyond hospitals to downstream providers, such as nursing home, pharmacies, clinics, or other community-based organizations, because they need help too?
Sure. So that was Assemblyman Godfrey's question as well, and I don't have that number off the top of my head, but I'm happy to provide the committee with a detailed breakdown. The thing about DSRIP is it's a very transparent initiative. So each and every quarter, each performing provider system has to provide a very detailed report to the state. And in that report is a lot of information. Those reports are all made public and posted to the website. But what we'd be happy to do is to basically, out of those reports, sum up out of the reported budgets as well as actual expenditures, the breakdown by provider type, so you can get a real specific answer to your question.
Thank you.
Thank you, Assemblyman Oaks.
Yes, we've also been joined now by Assemblyman Walter.
Next, Assemblyman Rhea.
Thank you. Thank you for attending and taking the questions. I know it's not easy, but I have two general policy areas. First off, the executive budget seeks to give Department of Health authority to establish pharmacy reimbursement rates for specialty drugs using the department's data, correct? How many specialty drugs would this be applied to?
Do we have a number?
So the proposal is that we do have information from a pharmacy benefit manager that many plans contract with that suggests that in the case of fee-for-service as well as generally in managed care that we are paying prices in excess of what is already being achieved in the same marketplace. And so we're using that information to propose adjustments on a drug-by-drug basis. Off the top of my head, I don't remember how many specific specialty drugs are to be impacted, but we can get you that analysis.
That'd be helpful.
Happy to do so.
Thank you. So where are you obtaining the data from? You just mentioned a specialty.
We obtained it from a price list and pricing information that was obtained through one of the pharmacy benefit managers. That's one that's contracts with quite a few of our Medicaid managed care plans.
Is that information available to the legislature or the pharmacies or the folks that might be affected?
So there's certain information. The challenge with drug pricing is some information is proprietary, but I believe the information that we have is available, and I'm happy to get you whatever it can be made public. Yes.
Thank you. Is it possible that the new rates that we're going to be talking about could wind up paying pharmacies less than their actual costs?
It's a good question. Certainly our goal here is not to have pharmacies lose money as a result of participating in the Medicaid program. If they do, chances are they'll exit the program. We've enjoyed throughout Medicaid's history in New York very wide participation amongst pharmacies and continue to do so today. I can say that we have a mechanism in place that if a pharmacy can document to the state that the rate of reimbursement or the rate that what they're paying to acquire the drug ingredient is higher than what we're reimbursing them. There's a mechanism for them to provide that information, a 1-800 number they can call, and then once we can document that's true, we have the ability then to increase the price, not only for that pharmacy, but if we believe that that's a systematic issue, we can increase it generally so that it won't impact other pharmacies as well.
Let me add one thing about the pharmacies in general. We feel as we move forward in transforming the system that the role of the pharmacist and the role of the pharmacy is critical to the success of what we're trying to do. We feel that they should be more integrally involved in some of the things that we've asked. We've seen this with with flu shots, but that's just the beginning of where we're at. And I think that in some parts of the state where many people don't have the chance to get to their doctor's much further away, the person in the healthcare system that they are most familiar with usually is the pharmacist. So I think that as we move forward with our plans, we are looking and reaching out to the pharmacy community and to the schools of pharmacy to address that as well.
Thank you. My next question deals with the current level of the tobacco control funding. What is budgeted for that this year?
So we continue to move forward with pushing to be as successful as we are in decreasing young people from starting to use tobacco, as well as getting those who are using tobacco to stop. This is part of our prevention agenda, and I can get you the exact numbers of the amount of money that will be put into that program.
So is it an increase over last year, or what's allocated in the budget this year?
I have to check and see what we have in the exact amount.
Okay. If you could get back to me on those numbers, because I guess the concern is particularly in certain areas of the state, lower socioeconomic areas, we may be making a dent in other places, but certainly in our inner cities, the numbers are certainly increasing.
Right, and this is, as we've been pushing, this is one of the most important things we can do in the prevention agenda, and clearly we know the risks of tobacco, so we would not want to have anything fall back on that initiative.
Okay, thank you. I yield back my time.
Thank you, Senator.
Thank you. Senator Gustavo Rivera.
Thank you, Senator. And thank you both folks for coming. I have a couple of questions. I reserve the time to also go in afterwards. There's a couple of things that, first of all, before anything else, most of what Senator Hannan says, I want to kind of echo. A lot of the concerns about what is not in the document are certainly need to be discussed. In particular, as far as the money that has been previously allocated for capital funds across the state. I do not live in Brooklyn, but certainly share many of the concerns that many of my colleagues does. Certainly, Senator Passaudt and Senator Savino both share concerns about their constituencies in Brooklyn. And also the concern that we all share about the impact that Health Republic has in other insurance across the state, and particularly the coverage that has already been issued, has already been done, right? How people have been cared for, and then the cost that many institutions and particular individual doctors have had to swallow. Certainly we have to figure out where that's coming from. But there's two things that you didn't talk much about, Commissioner Zucker, that I wanted to get into. At least the initial proposed budget does include an amendment to the local contribution on Medicaid expenditures. It is something that was not mentioned in the, it has obviously been talked a lot about, but it wasn't in your testimony this morning. I wanted to, is that something that still is in the, it's still in the proposed budget, as it hasn't been changed yet? That is still going forward as it's structured in the initial budget that we got?
So we, do you want to address the New York City issue? Sure.
So yes, so there is a proposed change in the budget relative to New York City's contribution to the Medicaid program. I think that the bottom line is that proposal obviously helps the state in terms of funding the state share. The state has been picking up an increasing amount of the cost of the Medicaid program. And to a great extent to a tremendous benefit to particularly counties as well as the city of New York. And I think that since the city of New York is obviously the home of over 50% of the total Medicaid expenditures in the state, the governor's proposal suggests that that they pick up a bit more of that expense. But I think at the same time, what we're committed to doing is working with the city, that if there are things we could do, efficiencies that could be found that could avoid the need for that change, I think we're open to that. And open to discussions with all of you as we move through the budget process about that particular proposal.
There's a lot of numbers that have been thrown around. What is your estimate as far as the cost to the city of New York?
Correct. Our estimate is that for the first year, I think it's about $195 million. It could be wrong off the top of my head, but that's approximately it. would be the cost. But I think you also have to take into account that into a broader perspective in terms of other enhanced federal funding and other things that are going into the city at the same time. We think that if you look at it in totality, we believe certainly that it's affordable for the city.
There's many of us that disagree with you on that, but that is what these conversations are for. And just to make sure that I'm clear in my head, so explain to me again the reasoning for the proposals to change it just for the city of New York and not change it for anybody else?
I think at the end of the day, it's an analysis of ability to pay and where the costs of the program are. And I think that at the end of the day is it. I mean, I think we've heard loud and clear the concern from the city about the change. And that's where I think that certainly you've heard from the governor and from his office a desire to be open dialogue with them and with all of you in terms of that particular proposal as we work our way through the budget process. And so I think we remain very interested in that discussion and talking about, we certainly do not want this to negatively affect the citizens of the city of New York.
We certainly agree on that. The second part has to do, the second set of questions has to do with the minimum wage proposal that the governor's put forward. Many of us are certainly thankful that the governor has put that forward, but many of us have been fighting for a minimum wage increase certainly for as many years as I've been here, and certainly many more years for folks that have been here a little bit longer. But regarding the impact, because certainly Senator Young pointed to something that many of us are concerned about as far as the costs to particular organizations or institutions. I have a couple of questions about that. As far as has there been an estimate on the offset from workers that once they get the raise, they're going to transition out of Medicaid? I figure there's many workers who currently find themselves eligible for Medicaid because they have the salary that they do, but once the salary goes up, they might be off of Medicaid. Has there been a calculation about the offset of those workers coming off of Medicaid?
Well, we could get back to you on exactly the details of that, of how many would move out. We have had great success with our marketplace and with people moving in into our New York, the exchange, and so we also have some numbers on that as well.
Okay. And I guess there are going to be continuing conversations about what exactly the phase-in would be, the cost that it would have, and then what needs to be offset from the state. That's all for now, but I might come back. Thank you.